All right, listeners, future MSRA superstars. Let's get ready for another deep dive.
That's right.
We're tackling a topic that I know you guys are going to see on your exam.
What?
So many people have written in about this, and we've got a whole stack of resources
Yes.
to go through. We've got NHS guidelines. We've got that in-depth RCM learning modules. We even got some recent research papers. People have sent in some of their own notes. So we're going to distill all this down to the key info that you need for those MSRA questions. We are talking all about acute pericarditis.
That's right.
So before we get into the weeds, let's start with the basics. If you saw the term pericarditis on an MSRA question, how would you explain it? Just the basics.
Well, I think the NHS website puts it really nicely. Pericarditis is simply inflammation of the lining around the heart,
Okay.
which is the pericardium.
So the pericardium, that little sac, it's getting all irritated. That's the basic idea.
Yeah, exactly. And the pericardium is a fluid-filled sac.
Mm.
So when it gets inflamed, you can get this buildup of extra fluid. And that's a pericardial effusion. And that effusion can sometimes lead to complications, which we'll talk about.
Okay. So we've got that. We've got this inflammation, potential for fluid buildup. But what causes it? What actually brings on this pericarditis?
Well, this is really interesting, especially in the UK, because RC Learning highlights that most cases of acute pericarditis are likely viral. Even if we label them as idiopathic, the stats suggest that most of them are probably viral.
So even if we don't know the exact cause,
Exactly.
we're kind of assuming it's viral in a lot of these cases.
Yeah, and that's really important for you as a doctor preparing for the MSRA, because it means that you're not necessarily going to be jumping to do lots of expensive and time-consuming tests trying to find the exact virus, because most of the time, these virally induced cases will resolve on their own.
With some relatively straightforward management.
Exactly.
Okay, that makes sense. So it's not always a huge workup.
Yeah.
But aside from these mystery viruses, what other causes should we be thinking about, especially for those MSRA curveball questions?
Of course. Well, the sources mentioned bacterial infections, particularly TB, although that's less prevalent in the UK compared to other parts of the world.
Right. TB, important globally.
Absolutely.
But maybe not as much in the UK.
We also need to think about autoimmune disorders,
Okay.
like rheumatoid arthritis and lupus. And these conditions can cause inflammation in various parts of the body, including the pericardium.
So you're thinking infections, autoimmune, anything else?
Yeah, one more important cause to remember is after a heart attack. So post-myocardial infarction pericarditis, sometimes called Dressler's syndrome.
Dressler's. Okay,
Yeah.
got it. So the heart's been through it, and then it gets inflamed on top of that.
Exactly.
Sounds rough.
It can be, but it's not as common as some of the other causes.
Okay. So we've got a good understanding of the potential culprits.
Yeah.
Now, let's put on our MSRA examiner hats. How might they test our clinical knowledge? What kind of tricky scenarios might they present to see if we can spot pericarditis?
Oh, they love to do that.
Well, yeah.
Okay, so let's imagine you're in the emergency department and a patient comes in complaining of chest pain. What features are going to make you suspect pericarditis?
Yeah, because chest pain, that could be so many things.
Exactly.
So what's going to make you go, maybe this is pericarditis?
Well, the chest pain and pericarditis, it has some very classic features. So it's usually sharp,
Okay.
it's a stabbing pain, and very importantly, it's positional.
What do you mean by positional? So it changes with...
It changes with position, yeah. So it's typically worse when lying down
Interesting.
and when taking a deep breath in. But it's better when sitting up and leaning forward.
So it's almost like positional pain relief, right? It's amazing.
Exactly. And this is a really important clue that can help you differentiate it from other causes of chest pain.
Because if you're having a heart attack, I don't think sitting up and leaning forward is going to help.
Not necessarily, no.
That's a good one to remember. Now, RC Learning really emphasizes this positional aspect of the pain. Are there any other specific pain patterns that we should be aware of?
Absolutely. And this is a real gem from RC Learning, and it could just help you snag an extra mark on that MSRA.
Okay, tell me.
Look out for pain that radiates to the trapezius ridge.
Trapezius ridge. Okay, that's specific. What's the connection there? Why would it radiate to the trapezius ridge?
Well, think about the anatomy. So the phrenic nerve, which supplies the pericardium, it also innervates the area around the trapezius muscle.
Wow, that makes sense.
So when the pericardium is inflamed, you can actually get referred pain to that region.
So smart. Okay, so we've got the sharp positional pain, maybe radiating to the trapezius ridge. What else might tip us off? Any other symptoms?
So along with the pain, patients with acute pericarditis might also present with fever, shortness of breath,
Okay.
and even hiccups or difficulty swallowing.
Hiccups. I never would have thought of that.
It might seem strange,
Yeah.
but remember the pericardium is right next to the diaphragm, which is involved in both breathing and hiccuping, so the inflammation can irritate the diaphragm and trigger those hiccups.
It all connects.
Yeah.
I love it. Okay, now there's another classic sign I keep seeing, that pericardial friction rub.
Oh.
What is that all about?
Well, this is a distinctive scratching sound that you can sometimes hear when you're listening to the patient's heart with a stethoscope.
Okay.
It's caused by the inflamed layers of the pericardium rubbing against each other.
Oh, so the actual sound of that inflammation.
Well, exactly.
Ouch. How often do we actually hear this rub? Because I know in medicine, sometimes those classic signs,
Yeah,
they're not always there in real life.
that's very true.
Yeah.
And RCM Learning says it's present in about a third of cases.
Okay.
And it can be what we call dynamic, which means it might come and go.
Oh, wow.
So it's important to repeat your examination.
So you can't just listen once and be like, nope, no rub, moving on.
Exactly. It might appear later on.
That's good to know. So we can't always rely on it, but if we do hear it, that's a pretty strong sign, right?
Absolutely. It's very specific. And combined with all those other symptoms we've talked about, it can really help you make that diagnosis.
All right, so let's say we're in the ED, we've got a patient, chest pain. Based on everything, we're thinking, pericarditis.
Yeah.
But we need to confirm it, right? What investigations do we order? Keeping in mind NICE guidelines and UK practice.
Yeah, that's where it gets really practical.
Yes, and this is the MSRA gold, right?
Absolutely.
What are they going to want us to know?
So the first investigation that should come to mind is the ECG.
The ECG, the bread and butter.
Absolutely, can't live without it.
But are the ECG changes always present in pericarditis?
That's a really important point. No, they're not. RCM Learning says those classic ECG changes are only seen in about 60% of cases.
Okay, so just over half the time. So what kind of changes are we looking for? Because I know there are different stages.
Yeah, and RCM Learning actually has a great visual breakdown of the 4 stages of ECG changes in pericarditis.
But for the MSRA, I think the main thing to remember is that widespread ST elevation is a common finding.
Okay, widespread ST elevation.
But it's not always textbook, so don't rule it out just because you don't see those really classic changes.
So ST elevation is a big one to look for,
Yeah,
but keep an open mind.
exactly.
Got it. What about troponin? Now, I know that's crucial in heart attacks.
Yes.
Is it relevant in pericarditis?
Yeah, good point. So troponin, which as you said is a marker of heart muscle damage, might be raised in pericarditis.
Okay.
But unlike with heart attacks, it doesn't actually predict bad outcomes.
Oh, that's an important difference.
Yeah, and I think that's something they could easily catch you out with on the MSRA.
Oh, definitely.
Because it's a subtle difference, but it's important.
They'll slip it in there. All right, so we've got ECG, we've got troponin. Anything else we need to think about?
The other one to consider is an echocardiogram.
Echo.
Echo, yeah.
Yeah.
Short for that. And that's really important for ruling out those big red flags, large effusions, and tamponade. Right, because that's when the fluid buildup actually starts to put pressure on the heart.
Exactly.
That's bad.
Not good.
No. So the echo helps us visualize what's going on, how much fluid there is, how severe it is.
Yeah, absolutely. It gives you a nice, clear picture.
Perfect. All right, so we've talked about investigations. Now let's shift gears and talk about what we actually do for these patients. What's the mainstay of treatment for uncomplicated acute pericarditis in the UK?
Well, the mainstay is nice and straightforward. It's NSAIDs.
Okay, makes sense. We're fighting inflammation.
Exactly.
So we're hitting it with the NSAIDs, but are there any other meds that are commonly used in the UK?
Yes. And this is a key recommendation from many of the sources, including NICE,
Okay.
adding colchicine to those NSAIDs. And this can really make a difference because it not only helps reduce those initial symptoms, but also lowers the risk of it coming back.
So it's like a double whammy.
Exactly.
Knocking out that inflammation and preventing a recurrence.
And the good thing about it is, at low doses, it's generally well tolerated.
Right. So NSAIDs plus colchicine, our go-to combo. Now, I know steroids are sometimes used for inflammation.
Yeah.
But I'm noticing in the sources, they're not typically first line for pericarditis. Is that right?
Yeah, that's a really important distinction. Steroids are not the go-to for acute pericarditis in the UK. They're usually reserved for very specific situations, like if we suspect an autoimmune cause, or if they're not responding to NSAIDs and colchicine.
And why is that? Why are we holding back on the steroids?
It's all about that recurrence risk.
Uh-huh.
So steroids, whilst they can be very powerful anti-inflammatories,
Right.
they can actually increase the likelihood of the pericarditis coming back.
So it's a trade-off.
Exactly.
We don't want to just knock out the inflammation and then have it come roaring back even worse.
And it's about getting that balance right for the patient. And that's a key principle in medicine. And it's something they will be looking for in your MSRA answers.
For sure, yeah. Okay, so NSAIDs and colchicine up front. Steroids reserved for specific cases. Now, I think it's time to address the elephant in the room. Complications. We know pericarditis is usually benign.
Yeah.
But can things go wrong? What do we need to be aware of as doctors, especially those preparing for the MSRA?
Yeah, you're absolutely right. Whilst most cases do resolve without any major issues, there are a few potential complications.
Oh, okay, give us a rundown.
That we need to be aware of. So RCM learning gives us some stark statistics. 3.1% of acute pericarditis cases develop cardiac tamponade.
Well, okay.
And 1.5% go on to develop chronic constrictive pericarditis.
So small percentages, but still,
Yeah.
Those are not conditions you want to mess with.
Absolutely not. Serious stuff.
Can you just break those down for us? What are those?
Yeah, so cardiac tamponade is a life-threatening condition where the fluid buildup around the heart becomes so severe that it actually starts to compress the heart and prevent it from filling properly with blood.
Wow.
So that can cause a drop in blood pressure. And if it's not treated promptly, it can be fatal.
Yeah, that's a medical emergency.
Big emergency.
And what about chronic constrictive pericarditis? That one sounds...
Yeah, so chronic constrictive pericarditis is more of a long-term complication where the pericardium becomes thickened and scarred, and essentially it's squeezing the heart.
Oh, wow.
And so this can then restrict the heart's ability to pump blood effectively, and it can lead to symptoms like fatigue, shortness of breath, and swelling in the legs.
So those are the two big ones we need to be aware of.
Yeah.
What are the red flags? What should we be looking for to catch these early?
Well, this is where careful risk stratification comes in, and this is something they really emphasize in the UK and on the MSRA. We need to be really good at assessing patients for what we call high-risk features.
Okay.
So things like high fever, large pericardial effusion on echo, any signs of tamponade. So that would be the rapid heart rate, low blood pressure, lack of response to NSAIDs, all these things.
So basically, we need to be really attuned to our patients, watching for those subtle clues that something might be brewing.
Absolutely.
Okay. This is really making me think of those MSRA questions where they throw in that curveball.
Oh, yeah.
And you really have to pick up on the details to get the right answer.
They'll test you.
Yeah, for sure. So we've got a good grasp of the causes, the clinical presentation, the investigations, and the complications. But how do we take all this theoretical knowledge and actually use it to answer those MSRA-style questions?
Well, the examiners want to see that you can take all of this knowledge about pericarditis and apply it to a real-life patient scenario.
Right.
So they might present you with a case vignette and then ask you a series of questions to test that understanding.
Okay, let's play that game. Let's imagine an MSRA question about pericarditis.
Okay, let's do it.
What kind of case might they give us?
Okay. So let's say they tell you about a 35-year-old woman who arrives in the ED with this sharp, stabbing chest pain that started a few hours ago.
Okay, already sounds like pericarditis.
It does, doesn't it? What else do they tell us about her?
Yeah?
Well, they mention that the pain is worse when she lies down and better when she sits up and leans forward.
Okay, classic.
Classic.
Yeah.
Positional, yeah.
They might also mention that she had a bit of a cold last week.
Ooh, a recent cold. Viral trigger.
Could be.
Definitely possible. What about the physical exam? What are we finding when we examine this patient?
Well, on examination, you hear that classic pericardial friction rub.
Oh, there it is.
And her ECG shows diffuse ST segment elevation.
Bingo. It's all coming together.
It's all pointing to pericarditis.
But how would this actually be presented on the MSRA? What kind of question format should we expect?
So it's very common for them to use the SBA-style question, so single best answer.
SBA, okay. So how would this look?
So, for example, they might say, a 35-year-old woman presents to the ED with sharp pleuritic chest pain, worse when lying down and relieved by sitting forward. Examination reveals a pericardial friction rub. Which of the following investigations is most likely to confirm the diagnosis? Oh, okay. So they're asking us to apply our knowledge choose the best next step.
Exactly.
What kind of answer choices might they throw at us?
Oh, they could give you options like a chest x-ray, echocardiogram, ECG, troponin levels.
Right, right.
Maybe even a D-dimer just to throw you off.
Love that, love that. Throw a pulmonary embolism in there.
Yeah, exactly.
Just to keep us on our toes.
Exactly. See if you can pick the most appropriate investigation based on that scenario.
So in this case, what would be the best answer? What's the investigation that's really going to nail it down for us?
Well, in this scenario, the answer would be the ECG.
The ECG. Makes sense.
Yeah. Because while those other tests might be part of the overall workup, the ECG is the most specific investigation to confirm acute pericarditis.
Especially with those classic symptoms, the friction rub.
Exactly.
It's all adding up. Now, I know we've covered a lot of information here. For those listeners who are maybe feeling a little overwhelmed, what are the key, like the absolute must-know takeaways that they should focus on? Okay, so first and foremost, I think it's really important to remember that most acute pericarditis in the UK is likely viral, even if we call it idiopathic.
Viral. Got it.
And don't forget that classic positional chest pain, really characteristic.
Positional, worse lying down, better sitting up. Got it.
And don't forget that pain might radiate to the trapezius ridge, just to get that equator mark.
Extra point.
Absolutely.
Love it. And of course, NSAIDs plus colchicine, our dynamic duo.
Yeah, our first-line treatment.
And steroids, not so much in the UK.
Not first line.
Okay. And of course, being aware of those complications.
Yes, absolutely.
Tamponade, constrictive pericarditis, those are the things that we don't want to miss.
Exactly.
Okay, we've covered so much ground. Before we wrap up this part of the deep dive, are there any mnemonics, any memory aids, anything that's going to stick in our brains?
Well, that's the great thing about learning for the MSRA. You can use whatever works for you.
Yeah.
But there are a couple of good ones. For example, I like to use the mnemonic trapezius.
Right, for that pain radiation.
Yes, exactly. Or you could visualize those 4 stages of ECG changes. RCM Learning has got some really nice diagrams to help you with that.
Oh, nice.
Or you could come up with your own.
Yes, whatever works. Now,
Before
so sorry.
That's okay.
Go ahead, you were going to say something.
I was going to say, before we move on to the next part of our deep dive, I want to leave you with a bit of a thought-provoking question.
Ooh, yes.
Oh.
But hold that thought, because we are out of time for this segment. We will be right back with that question and more expert insights to help you absolutely crush that MSRA. Stay tuned.
We were talking about those complications right before the break.
Yes.
Tamponade, constrictive pericarditis.
Right, those high-risk features.
Yeah.
The things that we don't want to miss.
Exactly. And even though most cases are benign,
Right.
the examiners, they love to throw those curveballs at you
Oh,
to see if you can apply your knowledge.
see if you're really thinking clinically.
Exactly.
Love it. Now, speaking of applying knowledge, there's one more complication we should touch on before we move on. And it's something that people often trip up on in the MSRA, recurrent pericarditis.
Oh.
Those cases where it just keeps coming back.
The boomerang, yes.
The boomerang, exactly. It just keeps coming back. So recurrent pericarditis, definitely something we need to be aware of. Now let's shift gears a bit and talk about how this knowledge translates into actually tackling those MSRA questions.
Yeah.
We've covered the theory, but how does it all come together in practice?
Well, the examiners want to see if you can take all this information and apply it to a real patient. They'll give you a case vignette and ask you a series of questions to test your understanding.
Okay, let's pretend we're facing an MSRA question about pericarditis. What kind of case might they throw at us?
Okay. Let's imagine they tell you about a 40-year-old man presenting to ED with sharp chest pain.
Okay.
And this pain, it's worse when he lies down, better when he sits up.
Okay, so far so good. Sounds like pericarditis.
Yeah, it does, doesn't it? But here's the twist. They also mention that the pain radiates to his left shoulder.
Oh, to his left shoulder. Now, that's not the trapezius ridge pain we talked about.
Exactly.
Could this be something else entirely? Like, are they trying to trick us?
Oh, absolutely they are. They want to see if you can differentiate pericarditis from other conditions.
Right, because chest pain, left shoulder, that could be cardiac, right?
Exactly.
So how do we tell the difference? What other clues would we look for?
Okay, so in addition to that positional nature of the pain, you want to think about the quality of the pain.
Right.
So are they describing a crushing pressure?
The elephant.
Yes, the elephant on the chest, which is much more suggestive of MI.
Right.
Or is it more of that sharp stabbing pain, which is more typical of pericarditis?
So quality of pain, important. What about the patient's history? Would that give us any hints?
Absolutely. You want to find out if they have any risk factors for heart disease.
Okay.
So high blood pressure, high cholesterol, diabetes, family history,
smoking,
all those things. And also asks about any recent illnesses, especially viral infections, which, as we said, can be a trigger for pericarditis.
Okay, so we're gathering all this information, symptoms, quality of pain, history, to help us narrow things down. Now, what about the physical exam? Are there any specific findings that would point us in one direction or the other?
Yes. In the case of pericarditis, you might hear that pericardial friction rub.
Right, that scratchy sound.
Exactly. And on ECG, you might see those characteristic ST segment elevations.
Widespread ST elevation.
But again, remember, these findings aren't always present.
Right, we can't just rule it out.
So don't get tricked.
If we don't hear that rub or see those ECG changes. Okay, so let's say, based on everything, we're thinking pericarditis is very likely. What do we do next? What investigations do we order?
Well, your first line investigation would be an ECG.
ECG, always got to start there.
Yeah, absolutely. And those classic findings, as we said, widespread ST segment elevations.
But ECG changes aren't always present.
That's right.
So what else can help us confirm?
Well, you might think about bloods, so a troponin level to rule out MI.
Right, rule out that heart attack.
And an echo can be very helpful as well.
The echo, to see that fluid.
Yeah, to assess for effusion.
Okay, so we've done our investigations. It's looking like pericarditis. Time for treatment. What's the UK approach to managing acute pericarditis?
Well, as we said before, the mainstay is NSAIDs.
NSAIDs, ibuprofen, aspirin.
Exactly. Helps reduce that inflammation and pain.
And don't forget the colchicine.
Ah, yes. Colchicine.
Our secret weapon against recurrence.
Exactly. Really important for reducing the risk of it coming back.
Now, what about steroids? We talked about them a bit earlier.
Yeah. Steroids, generally not first line for acute pericarditis in the UK.
Right, because they can increase that risk of it coming back.
Exactly. And that's a classic MSRA trick question, They might present you with a patient with severe symptoms and ask about the role of steroids, and it can be tempting.
It's tempting, but go-to. Not the go-to in most cases. Okay, so we've got diagnosis, we've got management. Are there any specific scenarios, any red flags that would make us manage a patient more aggressively?
That's a great question. There definitely are some situations where you need to be extra careful.
Okay.
So, for example, if a patient presents with signs of cardiac tamponade.
Tamponade, that's the one
That's the big one, yeah.
gotta watch out for.
Yeah, rapid heart rate, low blood pressure, muffled heart sounds. That needs urgent action.
So if you see those signs...
If you see those signs, you need to act fast.
And what would we do in that situation?
That's going to involve draining the fluid from around the heart.
So a pericardiocentesis.
Exactly.
Okay, get that pressure off the heart. Are there any other situations where we might need to adjust our management?
Yeah. If someone has a large effusion, even if they're not showing signs of tamponade, you might need to consider draining that.
Right, just to be safe.
And of course, if there's an underlying cause that needs specific treatment, you need to address that as well.
Right, like if it's bacterial, we need to treat the infection.
Exactly.
Okay, this is highlighting how important it is to stay up to date. Know those guidelines, know the latest best practices.
Absolutely.
Are there any resources you'd recommend for our listeners who want to make sure they're fully prepared for the MSRA?
Yes, absolutely. A great resource is passthemsra.com.
Passthemsra.com, of course.
Yeah, lots of information there, practice questions.
They've got everything.
Tips specifically for the MSRA.
Love it. Now, before we wrap up this segment, any other memory aids?
Oh, yes. I have one.
Hit us with it.
When it comes to remembering the causes of pericarditis, I like to think of the acronym vitamin C.
Vitamin C for the causes of pericarditis. I love it. Tell me more.
Okay, so it stands for viral, idiopathic, trauma, autoimmune, metabolic, infective, neoplastic, and connective tissue disorders.
Wow. Okay, that's amazing. Covers everything.
On most of the bases.
And it's memorable. Vitamin C. I'm writing that down. So, great mnemonic, but I always say the best mnemonics are the ones you create yourself.
It's absolutely.
What works for your brain.
Exactly.
Okay, so much good stuff in this segment. From those tricky differentials to managing pericarditis in the UK. Now, before we move on to the final part of our deep dive, I want to leave you with a thought-provoking question.
So before the break, remember I was about to ask you something.
Yes. Our brains are full of pericarditis knowledge. Hit us with that question. What were you going to ask?
We've been talking about acute pericarditis, but what about when it keeps coming back? Recurrent pericarditis can be a real challenge.
Oh, that's a good one. The dreaded boomerang. What do we do for those patients who just can't seem to shake it off?
Well, when we're talking about recurrent pericarditis, the management can get a little trickier. NSAIDs and colchicine are go-tos for acute pericarditis.
Right.
They might not be enough for these recurrent cases.
So what are our options then? Do we just up the doses, or are there other treatments we need to think about?
That's where things get interesting. Some newer therapies are emerging. One to keep in mind is rilonacept.
Rilonacept, okay. I'm not familiar with that one. Tell me about it.
It's a type of medication called an interleukin-1 inhibitor.
Okay.
And without getting too deep into the immunology, interleukin-1 is a signaling molecule that's involved in inflammation.
Right.
So by blocking it, rilonacept can help reduce those recurrent pericarditis episodes.
So we're basically cutting off the fuel to the fire.
Exactly. We're stopping those inflammatory flare-ups.
That's clever. Is this something that's readily available in the UK, or is it still experimental?
It's not first line yet,
Right.
but it's definitely showing promise for those tough cases where other treatments haven't worked.
So something to keep an eye on.
Yeah, for the future. You know, the learning never stops.
Never stops.
Yeah.
And speaking of learning, if our listeners want to dive even deeper and really ace those MSRA questions,
Well, you know where to go. PassTheMSRA.com.
PassMSRA.com, they've got it all.
They've got great resources, practice SBAs, everything you need.
I can vouch for that. They really helped me when I was prepping for my MSRA.
Absolutely.
Yeah.
All right. So to wrap up this deep dive,
We've covered acute pericarditis from top to bottom.
we've talked about those classic presentations, UK management, those curveball scenarios that those examiners love.
Yeah.
We even touched on some exciting new treatments like rilonacept.
It's a lot to take in.
It is. But remember, recognizing pericarditis and knowing how to manage it, that's crucial for any UK doctor.
Absolutely. It's essential.
And having those key facts, those mnemonics, some practice questions under your belt,
Mm-hmm.
but that's going to give you a real advantage on exam day.
Yeah,
So best of luck to all our listeners on your MSRA journeys.
absolutely. You got this.
We're confident you're going to do great.
That's all for this deep dive. Until next time, keep those brains buzzing and never stop learning.